Thanks. I'm coming to you live from our new location in the LRC, and so it's my first time trying to Zoom lecture from here. We're going to be talking about neurogenic obesity after spinal cord injury, and briefly we'll talk through, as I usually do, spinal cord injury and its comorbidities. Particularly today, I'm going to be looking to demonstrate the causal relationship between obesity and metabolic syndrome, particularly as it's pertinent to those with spinal cord injury. So we'll talk through the physiological changes after spinal cord injury. Those are going to offer us, I think, unique opportunities to intervene with exercise and nutrition in a way that will foster collaborative research with this population and with others. And then we'll talk about a couple of the research opportunities that we have across the spectrum of PM&R. So again, central nervous system, as you all know, is comprised of the brain and the cord. Most of you are pretty familiar with the different levels of spinal cord injury as we've gone through our INSCI exam just recently. And the levels basically will indicate to the myotomes, that is the level of motor function, as well as the dermatomes. And then we have the autonomic nervous system to consider, particularly since the sympathetic nervous system arises from the thoracolumbar regions of the cord. So remember that the parasympathetic and sympathetic nervous system are a constant state of tug of war. Neither one of them, under usual physiological circumstances, neither one of them turn off completely, but they have relative increases or relative decreases. And yet, spinal cord injury provides a completely different scenario where the sympathetic nervous system is in fact blunted oftentimes. As you recall, the sympathetic nervous system again arises from the thoracolumbar regions of the cord, and it conveys our fight or flight, that is ergotropic responses. During a crisis situation, the sympathetic nervous system is what allows us to increase our heart rate, our blood pressure, allow us to mobilize energy substrates that allow us to get through the crisis situation. Following the crisis situation, typically we see an increase in parasympathetic nervous system activity. Parasympathetic nervous system conveys energy conservation, that is rest and digest. And so typically after a crisis situation, and we're in this mode most of the times, I hope, we are trying to replenish substrates that were utilized during a crisis situation, preparing the body in an anabolic way to prepare itself for the next crisis situation. And so spinal cord injury gives us a different beast to consider as we're comparing sympathetic and parasympathetic nervous system activity, in that we have significant sympathetic blunting under most circumstances. However, there are those circumstances in spinal cord injury where we get a noxious stimuli below the level of the injury that actually stimulates a sympathetic adrenergic response. And this was first described by Anthony Bowlby back in the 1890s as a massive sympathetic outflow in response to a noxious stimuli below the level of the injury. He called it incomplete spinal cord injury lesions above T6. We know that incomplete spinal cord injuries can also have this dysautonomia, complications of which include stroke, seizures, organ failure, and death, which are suboptimal. So why is T6 so important in terms of a physiological response? It really seems to come down to the fact that the greater splanchnic nerve arises from T7 and T8 in most individuals. And as such, if you have control over your greater splanchnic nerve, you have control over the splanchnic vascular bed, that is the largest vascular bed in the body. On the other hand, if you don't have control, in other words, your injury is at T6 and above, then a noxious stimuli below the level of your spinal cord injury could cause a sympathetic outflow, a reflex sympathetic outflow that causes splanchnic vasoconstriction and therefore a hypertensive response and in fact a hypertensive crisis. Now the other thing that comes off of the T7, T8 nerve roots are the nerves to the adrenal medulla. And remember, the adrenal medulla is also responsible for kicking out catecholamines, particularly epinephrine and norepinephrine, and therefore helps to mediate sympathetic response. So again, if you don't have control over this nerve, then you're going to end up having a pretty systemic catecholamine response. And so as we look at a noxious stimuli below the level of the injury, most typically we think of bladder distension or something to do with the genitourinary system. And so as we see bladder distension occurring, typically you have afferent impulses that ascend the cord but are blocked at the level of the spinal cord injury with a reflex sympathetic outflow causing splanchnic vasoconstriction and subsequently hypertension. Increased blood pressure is sensed by baroreceptors that send information to the medulla, which sends information back to the heart and ultimately causes a bradycardia. But below the level of the injury, the person remains vasoconstricted, whereas above the level of the injury, they vasodilate. We see flushing, sweating, and this set of symptoms that we call autonomic dysreflexia. I want to talk you through a case study. In fact, this was a young gentleman, an Army Ranger, who came to us when I was at the Richmond VA. Now, the Army Rangers are like the best of the beasts, and by beasts I mean these are the smartest, the most fit individuals in the Army system. And so this individual, unfortunately, took a sniper bullet to the neck at the very peak of his physiological and I would say intellectual abilities. He ended up having a C4 burst fracture causing significant C4 spinal cord injury that was complete. He also had mandibular fracture on the left side requiring surgical intervention. He was on mechanical ventilation when he came to us. He had a trach, a peg, and unfortunately a grade 3 pressure injury. So this gentleman, this warrior who was there serving you and I and protecting our rights and our freedoms, went from being the very peak of physiological excellence to having a significant number of comorbidities, all of which are listed here in alphabetical order mostly. But I want to really focus today on the issues of obesity and metabolic syndrome that he encountered within, I don't know, 6 to 9 months. He had left the rehab center, and when I saw him back at 9 months, was surprised to see such an increase in body fat. His body composition had changed significantly. So is body fat bad for you? Well, I would say yes. There are a number of things associated with obesity that we would herald as pathological and significantly dangerous to our health. The first several on this list are the ones that I'm going to spend most of my time talking about today, but recognize that along with excess adipose tissue come all of these other comorbidities. So again, we're going to kind of focus in today on those related particularly to metabolic syndrome. Now, can you be healthy and still be obese? There are a number of papers that are out there trying to say yes, as long as you're exercising and as long as you've got the genetic potential, then this shouldn't be a problem. Unfortunately, most of especially the more recent papers have demonstrated that despite a person's fitness level, a person with obesity does have significant risks. And so there was an interesting case study separate from the one that I just showed you, where they took, what was it? Oh, the statue of David put together by Michelangelo. And they brought that over to the United States several years ago and put it in the city of plenty, that is Las Vegas. And what we found happened to David happens to many of the people in our society, in that he developed over a relatively short course significant obesity and subsequently had some major problems associated with that. So what about obesity and spinal cord injury? Honestly, this really wasn't considered much before the turn of the century. And I was asked to put together a special volume in topics in spinal cord injury rehabilitation in 2007, where we reported out that obesity is, in fact, at epidemic proportions in persons with spinal cord injury. It's a secondary condition of spinal cord injury because of an obligatory sarcopenia. That is, people are going to lose muscle mass, a blunted anabolism, their anabolic hormones, growth hormone, etc., are diminished after spinal cord injury. They have the blunted sympathetic nervous system that I just described to you, and a positive energy balance, which in fact is not a positive thing. And we'll talk through that. Not only that, but we really went into the ways in which obesity mediates metabolic syndrome that is causing, in fact, insulin resistance, hypertension, dyslipidemia, thromboembolism, and coronary artery disease. Now, there's been a lot of work, a lot of science that has been done since 2007. And in fact, we are in the midst of a, not a rewrite, but a resetting in that in December, we're supposed to be putting forward a new issue on neurogenic obesity after spinal cord injury. And again, it will be in the topics in spinal cord injury rehabilitation. Metabolic syndrome is defined differently depending upon where you go for your definitions. The Adult Treatment Panel 3 of the National Cholesterol Education Project reports out abdominal obesity as a key factor, as well as dyslipidemia, blood pressure, and fasting glucose. The World Health Organization, on the other hand, cites insulin resistance as being the key factor, plus any two of the following, including high blood pressure, dyslipidemia, or obesity, as they defined it. In 2005, the International Diabetes Federation had a consensus panel where they brought people together around the table to define metabolic syndrome. And they, in fact, used, and this is the International Diabetes Federation, they used central obesity, that is waist circumference, plus any two of the following: dyslipidemia, elevated blood pressures, or fasting blood glucoses that were out of sorts. And these numbers have been used more and more frequently as we're defining the metabolic syndrome. Now you'll notice the dashed line between or through US men and US women. The Americans at the table got a little bit upset as the Europeans and others were saying, yeah, a waist circumference for men of 37 inches or for women 31.5 inches is considered obese. And the Americans said, whoa, 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 we've been telling people for decades that you're not really obese until your waist circumference is 40 inches as a man and 34.5 inches as a woman. And you know, the Europeans, they like to get along, and they say, okay, we'll put that in. Now, physiologically, we realize, however, that we should probably be using the lower numbers as we consider central obesity. What about in spinal cord injury? We looked at almost 500 veterans with spinal cord injury, a mean age of 56. About 50% of them had tetraplegia, meaning the other 50% with paraplegia. 3/4 of them had a BMI greater than or equal to 22 kilograms per meter squared. And I know what you're thinking. That's kind of thin, Dr. Gator. Well, yeah, it is, but not so much in spinal cord injury. And in fact, I'll present some data in a little bit that will show you that if you have a BMI of 22 as a person with spinal cord injury, you are in fact obese. That's, I know, hard for you to guys, any of you to imagine at the moment, but just bear with me. So 3/4 of these folks were considered obese. 70% had dyslipidemia with HDL cholesterol less than 40 milligrams percent. We had about 50% with blood sugars over 100 milligrams percent or under treatment for diabetes. And in fact, 55% with hypertension, which was somewhat shocking because usually I teach with regard to neurophysiology, a person with spinal cord injury has neurogenic hypotension, except for those with obesity, and we'll come back to that. So we had 57.5% of individuals with spinal cord injury actually met the metabolic syndrome as defined by International Diabetes Federation, and we reported this out just last year. So how do you manage metabolic syndrome? Well, nobody wants to look at that first line, but let me just come back to that. That's really what we're going to have to work on when we look at our folks with spinal cord injury. You don't want to use some of these other things, sibutramine, phentermine, orlistat. These things in spinal cord injury are in fact dangerous and won't make friends amongst our persons with spinal cord injury. Certainly we need to keep their blood pressure under control. We need to keep their lipids under control. And so using appropriate medications for those things I think is necessary. I have a little bit of an issue, although I'm not saying don't do it, but managing diabetes for persons with spinal cord injury. Recognize that if you give somebody with type 2 diabetes an insulin sensitizing agent, they are going to be more sensitive and be able to get your blood sugars down. But how do they do that? They do that by getting the blood sugar into the cells where now you're storing that sugar, excess sugar, as fat. And now you're actually increasing the problem unless you change the energy kinetics as we're going through there. So more on that as we go through this. We know that adipocytes, fat cells, impair fibrinolysis, and they do this by secreting sticky substances, thrombin activatable fibrinolysis inhibitor TAFI and plasminogen activator inhibitor PI. Both of those are sticky substances. Easy way to remember this. TAFI and PI impair fibrinolysis, that is, they increase the risk of thromboemboli. But we also know that adipocytes are pro-inflammatory and secrete a number of pro-inflammatory cytokines. I've got just a couple listed here: interleukin 6, interleukin 1, tumor necrosis factor alpha. Those will actually convert in the liver to C-reactive protein. C-reactive protein, we know, increases nuclear factor kappa B, decreases nitric oxide, and therefore we lose relative vasodilation, increases leukocyte adhesion and endothelial cell apoptosis results. So all of this is bad, and in fact, do we see higher levels of these inflammatory cytokines in persons with spinal cord injury? Well, yeah, way back in 2005, there were several publications that came out almost concurrently demonstrating this relationship between vascular inflammation, particularly using high sensitivity C-reactive protein, and demonstrating that relationship with metabolic syndrome. We also know that there's a pretty significant relationship between obesity and immunosuppression, in that this increased inflammation does, in fact, impair the immune system. Herman's manuscript in 2018 really demonstrated a difference in those folks with spinal cord injury, but particularly in red here, the folks with injuries above T6, and even those with injuries below T6 had significantly higher rates of not just obesity, but also immunosuppression compared to uninjured individuals. So again, without beating this to death, those folks who are found to be obese generally are found to have a pretty significant pro-inflammatory profile. The literature in recent years has been demonstrating more and more that this is a relationship between adiposity and not just some of the other things that we associate with spinal cord injury. For example, urinary tract infections, pressure injuries could also increase C-reactive protein and some other biomarkers of inflammation. But let me continue. Adipocytes also cause hypertension. So they do this by secreting, directly secreting angiotensinogen, which is a potent vasoconstrictor. That is, it increases this whole renin-angiotensin-aldosterone syndrome that we hear about. We talked about the relationship with nitric oxide, diminishing vasodilation. We also know that as you accumulate free fatty acids in the vascular tree, you're going to end up with atherogenesis, that is poorly compliant arterioles. The fat itself, the visceral fat, causes compression of the adrenals and also increases aldosterone and the whole renin angiotensin aldosterone system. And we first reported this back in 2007 amongst almost 8,000 veterans. We were surprised to see quite a few of them with blood pressures in the relatively high range. And in fact, 23% had blood pressures 140/90. And this was clearly, because we went back and checked, clearly unrelated to autonomic dysreflexia. And as we have subsequently concluded, is related to the number of adipocytes that these individuals were holding. Visceral fat also causes a dyslipidemia. We know that the increased number of non-esterified fatty acids that are basically overwhelming the portal circulation change the way that we make our cholesterol. So the LDL cholesterol is the bad cholesterol spewing out triglycerides and free fatty acids into the arterial tree, whereas the HDL cholesterol, the good cholesterol, comes by and cleans up the vascular tree. As you have more and more non-esterified fatty acids confronted in the portal circulation of the liver, however, what we see is an increase in the LDL cholesterol and a reduction in HDL cholesterol, so that we end up with this relative dyslipidemia. And it's been reported a number of times prior to the turn of the century, and then since then. Most recently, well, there have been a number of studies since then, but in 2007, Bauman and Sponged reported out 2/3 of individuals with spinal cord injury had HDL cholesterol less than 40 mg/cent, which is considered problematic. Of note, though, 20% had HDL cholesterol less than 30 mg/cent, which means that they are at high risk of developing rapidly arteriosclerosis. But wait, there's more. Adipocytes also cause insulin resistance. They do this through the secretion of these pro-inflammatory cytokines, but also as you increase fat within particularly the liver and muscle system where a lot of our insulin receptors are sitting, you inhibit the PI3 kinase cascade, where you have fatty acyl-CoA, diacylglyceride, and ceramides accumulating within the cell. What are you talking about, Dr. Gator? I don't remember this. So you have a cell, and let's say that it's a muscle cell or a liver cell. And outside of the cell in the vascular tree, you have glucose accumulating. And as you accumulate more and more glucose, basically it stimulates the release of insulin from the beta cells of the pancreas. That activates the PI3 kinase, which in turn activates the GLUT4 inactive receptors, allows them to migrate to the cell membrane, and allows the passage of glucose into the cell. What we know now, though, is that there are at least 8 different ways in which obesity, and particularly the increased, again, diacylglycerides, the ceramides, et cetera, accumulating within the cell, these all impair insulin sensitivity. And so more and more we're recognizing the problems, particularly in spinal cord injury, and realizing that there's also a relationship with the level of injury, probably tied to body fat, which has been demonstrated to be higher in folks with tetraplegia than in paraplegia. But also there are other things contributing to this. And so we continue to look at these relationships. Again, should we be managing this? Yes, we should go through the typical diabetes, American Diabetes Association care guidelines, starting with metformin, and then as necessary, move forward to manage this. But recognize, if you only increase insulin sensitivity, then you're going to be increasing the storage of fat, which is going to make your overall metabolic syndrome worse. And we demonstrated some time back, again, around the turn of the century, the lime green lines here. This is an oral glucose tolerance test. Those of you who have not had the opportunity to take this. This is a glucola beverage. You drink down 100 milligrams of glucose, and then at T0, we start measuring your blood glucose levels. And so at 30 minutes, 60 minutes, 90 minutes, 120 minutes is usually the 2-hour glucose tolerance test. We've actually extended it to 3 hours in these studies and demonstrated that persons with tetraplegia in the lime green have significantly higher area under the curve. That is a relative glucose intolerance compared to the pink line, which is able-bodied individuals, age and gender matched. And then persons with tetraplegia are in blue here. So all spinal cord injury are listed in red. And again, significantly increased areas under the curve, that is a representative of glucose intolerance in persons with spinal cord injury compared to able-bodied individuals. And yes, there appeared to be a relationship with percent body fat, in that the higher levels of percent body fat also had greater areas under the curve for a glucose tolerance curve. And this, in fact, we were looking at all levels of spinal cord injury. When we looked at just paraplegia and took out the autonomic component of this, we see a very, very tight line, and that relationship becomes very, very clear to us. So we'd recently published this, Dr. Nash here with the Miami Project, chaired this panel, and I participated as well, talking about cardiometabolic risk after spinal cord injury, basically reiterating the things that we had demonstrated in 2007, that our folks with spinal cord injury are increased risk because of their obesity, their prediabetes, hypertension, and dyslipidemia. And the recommendations, ooh, everybody shudders with those first two: nutrition and physical activity, as well as pharmacotherapy. So why do these folks have such high body fat? And I want to just briefly talk to you a little bit about energy balance, energy expenditure on the left in this slide, energy intake on the right. Somehow we need to achieve energy balance. So let's go back to our case study, the gentleman that I talked to, the Army Ranger with C4 spinal cord injury. As he came to our center, they got a nutrition consult, and the nutritionist hadn't worked with folks with spinal cord injury. And so she used the usual Harris-Benedict equation for men, which was developed, in 1918, yes, and we're still using it. And based on basically the person's weight, their height, and their age. She had determined that this 24-year-old man with a body weight of 160 pounds, 6'1", would have a predicted basal metabolic rate of approximately 1,825 calories. Now, the Harris-Benedict equation requires you to make correction factors. Even for sedentary individuals, they ask you to add 20%. But for somebody who had recently had trauma, such as our Army Ranger, they recommend a 60% increase, so that his predicted energy needs were 2,900 calories a day plus change. And I was a little concerned about that. And I said, well, can we at least measure? We were able to wean him off the ventilator and do indirect calorimetry on him, and actually demonstrated resting energy expenditure of 1,280 calories a day. And that, I'm not great at math, but that represents a mismatch of approximately 1,640 calories per day. That is a positive energy balance. So over the course of a week, he would have gained 3.2 pounds of fat. And over the course of his first month on our service would have gained 14 pounds of fat, which we wouldn't have recognized because, by the way, he was losing muscle mass due to disuse and bone mass at the same time. And so when you look at this, it becomes pretty clear this is going to be a problem for us. Now, it says my session is about to expire. I hope that's not true. So let's go back to the 1990s. Rodriguez out of New Mexico looked at spinal cord injury compared to non-spinal cord injured trauma patients. And they said, let's overfeed these folks by 20%. Let's, in fact, give them 2.4 grams of protein per kilogram of ideal body weight per day, and see if we can keep them from losing muscle mass. And what they found was that 2 months out, the folks with spinal cord injury were still losing significant nitrogen, that is protein, that is muscle mass, whereas they achieved nitrogen balance by week 3 in trauma patients who were overfed and given extra protein. They repeated the study several years later with very similar findings and said, you know, it's inappropriate to use these predictive energy expenditure equations, but if you're going to, certainly don't use the multipliers that are typically associated with the Harris-Benedict equation, because these folks have an obligatory sarcopenia, muscle atrophy due to paralysis, and as their muscle mass and bone mass decreases, so does their resting energy expenditure. And therefore, if we don't modify their intake, similarly, they're going to gain fat mass. Let's see, I'm trying to get back on board here. There we go. Resting energy requirements. So all of us are burning calories even at rest. The liver, approximately 30% of our total daily energy expenditure, depending upon how much fun you had over the weekend, I suppose. Your heart burns about 10% of your total daily energy expenditure. Your kidneys, 7%. The brain, for most folks, somewhere around 20%, obviously all of you, more like 25, 30% of your total daily energy expenditure is expended by the brain. Skeletal muscle, however, is the most variable component of the resting energy requirements. And what we've seen, and this is crazy, you can take a look at this equation, apply it to children, apply it to the elderly, apply it to women, apply it to men, and we still find this very tight relationship between fat-free mass, muscles, bones, and organs, not violins or guitars, by the way, and then resting energy expenditure. So the higher your fat-free mass, the greater your resting energy expenditure. Now, daily energy expenditure is comprised of your resting or basal metabolic rate, the thermic effect of activity, and the thermic effect of a meal. Approximately 2/3 of your metabolic daily energy expenditure is resting metabolic rate. That is the energy required just to keep the body alive. And then the thermic effect of activity, between 15 and 30% of your total daily energy expenditure. And the thermic effect of a meal, yes, it burns calories to digest food. Don't think that you're going to be able to make up for all the food that you eat. However, you don't burn that many calories just digesting, I'll tell you. This, however, is important for you to recognize. If you look at, let's say these were three-dimensional pyramids, total daily energy expenditure for an able-bodied individual, approximately 2,800 calories a day for somebody my size, age, and activity level. If I was to sustain paraplegia and look at the change in my energy expenditure, I would drop by about 25%, somewhere around 2,240 kcals per day. If I was to sustain an injury that left me with tetraplegia, I would drop to about even less than 50% of my previous daily energy expenditure. So if I didn't compensate by changing my intake, then I would see a pretty positive energy balance, such that over the course of the year, I would probably gain 20 plus pounds of fat, not weight, fat. Now, when I say not weight, that's because I'm also, with a new spinal cord injury, likely to lose muscle mass, bone mass. Muscle and bone are more dense, by the way, than fat. And so a person can come in having lost weight after a spinal cord injury and still have gained significant amount of fat. And so again, coming back to this energy balance picture, trying to increase energy expenditure by 100 kcals a day, decrease energy intake by 100 calories a day, might be able to achieve energy balance for someone like myself. Now, BMI, I mentioned earlier. For most of us, we think BMI 25 and below is kind of normal weight. 25 to 30 is considered overweight. And then a BMI of 30 and above we think of as obese. This is non-spinal cord injured individuals. What we've demonstrated in folks with spinal cord injury, however, is that their lean mass, their fat-free mass, decreases significantly after spinal cord injury. And there was really an exquisite study done by Bill Bauman and Spungen in 2004, where they looked at, from around the globe, they found persons with spinal cord injury who had a twin. And what they found was, in these monozygotic twins, when you make a comparison, there was a significant reduction in fat-free mass, and a significant reduction in total daily energy expenditure compared to the non-injured monozygotic twin. So, crazy study. Loughton reported out in 2009 a spinal cord injury with BMI greater than 22 kilograms per meter squared was at risk for obesity, and they were using bioelectrical impedance analysis. Not ideal when you look at spinal cord injury because of the shifts in intracellular, extracellular water, et cetera. But if you look at studies with different methods of assessing body composition, and particularly we look at a 4-compartment model, which is the gold standard. I'll come back to that in a moment. Generally, what we see is for a BMI under 25, we see a spinal cord injury person with percent body fat more than 33%. And so a BMI of approximately 25 in spinal cord injury represents more than a third of their mass. Let me say that again, more than a third of their mass is fat mass. And so what is their optimal body weight? If we could look at something besides just body mass index and use body composition assessment, where we essentially strip the body down into its respective components of muscle, bone, and fat. And they did this actually back in the 50s and 60s. They looked at 3 male cadavers. This is how we established the science of body composition assessment. And they determined density for fat and fat-free body mass, including water, protein, and minerals. And so over the years, there have been a number of body composition techniques that have been used in able-bodied populations. And unfortunately, until recently, those haven't been validated in the spinal cord injury population. Now, even in the able-bodied population, if we want to look at comparisons between ways to assess body composition, generally speaking, we'll use as the gold standard the 4-compartment modeling. And the 4 compartments that we're looking at include fat, total body water, bone, and residual dry mass. Generally speaking, the 4-compartment modeling requires underwater weighing or hydrodensitometry, DEXA scans to determine bone mineral content, and then determination of total body water, either using deuterium, D2O, dilution techniques, or bioelectric impedance analysis. And we had done this with persons with complete motor complete spinal cord injury, 72 individuals, among them 59 men and 13 women. Mean age was 44. Their BMI on average was 27.3. And what we found is that for a average BMI of 27, their percent body fat by 4-compartment modeling was 44%. 44% of their body was fat mass. And so these folks essentially are swimming in fat, like no other populations that I've ever studied, with more than twice as much excess body fat as we see in the able-bodied population. And associated with this included elevated high-sensitivity C-reactive protein, elevated by more than 4 times normal, and elevated plasminogen activator inhibitor. Remember, that's the fibrinolytic, anti-fibrinolytic agent. So I think it's very important that we reestablish energy balance. We can consider other pharmacological options as we look at this. We can consider energy expenditure. I'm an exercise physiologist. Why not? Why wouldn't we? And so having a couple of exercise physiologists in our departments, we're all pretty excited to teach you about the science of exercise physiology. We could look at body composition or coronary artery disease risk reduction. We could use aerobic exercise or anaerobic exercise. We can look at motor control and neuro recovery. But really what I want you all to focus in as PM&R residents and medical students is how do you put together an exercise prescription? And again, remember, your prescriptions include your diagnosis, comorbidities, the goals, probably the most important part of your prescription, the limitations, the environment, the mode, frequency, intensity, duration, and progression of the exercise plan. And also recognize that you do have a few, limitations in persons with spinal cord injury, more than you're going to see in any of the other populations that you're going to try to test or prescribe exercise for. And so if we went to the American College of Sports Medicine and we talked about exercise screening, we would screen for risk factors and we would screen for major signs and symptoms. Not lieutenant, not general, but major signs and symptoms. And so the risk factors you all know, basically, those with hypertension, those with dyslipidemia, those with fasting blood glucose abnormalities, those with obesity. The hard thing with our spinal cord injury folks is the ones that have already gotten boxes here, most of them already hit those risk factors. And then signs or symptoms. Apply this to persons with spinal cord injury. Many of them have shortness of breath on exertion because they're restrictive lung disease, neurogenic based, dizziness and syncope related to their spinal cord injury, circulatory hypokinesis, ankle edema, gravity dependent in those folks that are sitting, most of it in their chairs, and then an unusual fatigue or shortness of breath with usual activities. So can you actually use these to, quote, determine risk for persons with spinal cord injury? Probably not. And in able-bodied individuals, we would move forward with graded exercise tests. And those at high risk, we would want to do a graded exercise test with a physician present. And I would just say that for our folks with spinal cord injury, you're probably going to want to have a physician present anyway, because these folks are going to be at high risk, basically. Signs and symptoms listed on the previous slide, or known cardiovascular metabolic disease. Now, one other thing I want you to consider with your exercise prescription for persons with spinal cord injury. They're, generally speaking, lower extremities are paralyzed. That is, they can't voluntarily activate those muscles. And so they're going to be limited to a large degree to upper extremity work in terms of burning calories and whatnot. Now, even in able-bodied individuals, and I challenge you to come to our exercise lab and spend some time with us, we find that upper extremity work achieves a heart rate, a relatively high heart rate relatively quickly with relatively small change in oxygen uptake. That is, they're not burning as many calories as somebody who does lower extremity work at a similar heart rate burns many more calories. Why is that? They have much more muscle mass that is active and therefore activatable. And so those persons relegated to upper extremity work, that is persons with spinal cord injury, can't burn as many calories as they could have if they were prescribing lower extremity work. And yet their sense is, if we were to ask them on a Borg assessment scale how hard they think they're working and compare that to their heart rates are relatively high, but they're not burning many calories. And so how do the rest of us burn calories through exercise? Barb Ainsworth put forward way before the turn of the century a compendium on physical activity. And this is a list of tables of all kinds of activities, from raking leaves to swimming to playing volleyball to playing billiards to dusting your house. And they said, this is how many calories are associated with each of these activities. And yet we didn't have those kinds of activities or a compendium to put together for our folks with spinal cord injury. And so we were able to, there were 3 groups when I was in Ann Arbor. We collaborated with folks at the Hines VA in Chicago and the Palo Alto VA in California. And basically, we put together our own compendium with 170 veterans with spinal cord injury, looking at 27 physical activities. We put together how many calories they burned for each of those activities at a certain level. The other thing that we did was a metabolic equivalent, MET. In able-bodied individuals, everybody is taught that a metabolic equivalent means that you're burning 3.5 milliliters of oxygen per kilogram body weight per minute. That's the oxygen consumption, and it's tied directly to calories, the number of calories expended. For persons with spinal cord injury, a metabolic equivalent in general was 2.7 milliliters per kilogram per minute, which is significantly lower. And if you look at tetraplegia relative to paraplegia, their one metabolic equivalent was down around 2.2. So recognize that energy expenditure, unfortunately, is just not as great for persons with spinal cord injury. So we've got, and I've contributed to the literature in this, ways to prescribe exercise for cardiovascular fitness, for strength and power, for persons with spinal cord injury, for flexibility, and yet, is this how we should be prescribing exercise? Some of you may, I love this movie. This was a great movie because it looks at rehabilitation, and basically they fashioned an artificial arm for Will Smith, who's a detective in this, and he's trying to determine a murder of Dr. Alfred Lanning, who actually built the robots and the robotic arm that he uses. And anyway, Dr. Lanning was murdered, and yet there was this little box that would respond to questions in advance that he had with him, and yet in order to get a response, you had to ask the right questions. So you would ask him something like, how should we prescribe exercise in people with spinal cord injury? And he would say, I'm sorry, my responses are limited. You must ask the right questions. And so I'd get specific, and I would say, is it possible to achieve negative energy balance after spinal cord injury? That, detective, Dr. Gator, investigator, that is the right question. And so, again, I look at the spinal cord injury comorbidities and I say, how do I prescribe exercise for fat loss? If we go to the ACSM guidelines, American College of Sports Medicine, and they've probably been updated again more recently, but in 2015, they said people should do mild to moderate activity, that is 300 to 400 calories per day, or about 2,000 calories a week to get in general fitness. And the Dietary Guidelines of America, also in 2015, said 60 minutes a day of exercise to maintain, or 90 minutes a day of exercise for weight loss. Now, again, mild to moderate activity, that is at the highest level of functional ability for most folks with spinal cord injury. What do I mean by that? We tried exercise to reduce obesity and spinal cord injury. In a 3-year interventional study, we provided 16 weeks of aerobic exercise, either through arm crank ergometry or leg cycle ergometry through functional electrical stimulation in individuals with T4 to L2 spinal cord injury. And we looked at our primary outcomes as body fat, insulin sensitivity, and VO2 peak, with a number of other variables that we were looking at. And the bottom line was, down at the bottom here, we had a significant reduction in percent body fat, systolic blood pressure, diastolic blood pressure. We increased fat-free mass in both groups, arm crank as well as functional electrical stimulation, leg cycle ergometry. We increased HDL cholesterol and increased energy expenditure per session, but body weight increased. And actually their community mobility got worse because their body weight increased. They increased their muscle and bone mass, but they also increased their fat mass because we didn't control their diet. I should have, but I didn't. Of note, however, I want you to see this. On their first ride, they didn't burn 100 calories in an exercise session. I can walk around the rehab center a couple of times and burn 100 calories, just so that you know. In the middle of the study, by 8 weeks, however, they had increased their energy expenditure per session to 200 calories per session, and by the end, close to 250 calories per session, because they had increased the muscle mass in their legs and their ability to exercise fully as we went through that. So again, there's energy expenditure. This is going to be hard. But the other way to modify energy balance is to change our energy intake. And so regulation of food intake, as you know, is a little bit complex, but I really want to focus your attention up in this right-hand corner where it says external factors. Now, what does that mean? That means your emotions, the food characteristics, your lifestyle behaviors, and environmental cues. Forget the billboards and the advertisements on TV and all of those, have it your way, etc. All of this contributes. Now, in the brain, we've got the hypothalamus, and within the hypothalamus, areas that tell us about when we're full or not. Except that after a spinal cord injury, even those centers are blocked because they don't get the full influence coming back from the stretch of the stomach, for example. So there are a number of different things that persons with spinal cord injury don't sense, and they don't know that they're full. So what are their caloric requirements? Way back in 1985, Cox reported out with just a few individuals that generally speaking, persons with tetraplegia should only have an intake of about 10.3 kcals per pound per day. Or those with paraplegia, about 12.7 kcals per pound per day. Even if you try to figure this out, it's not completely accurate. And in fact, we need to be able to determine energy expenditure a little bit better. So we look at direct calorimetry. We put somebody in a bomb calorimetry, if you will. And then we blow them up and see how many total calories were in there. But no. That's generally speaking, we're not allowed to do that under human subjects. Institutional review boards generally frown upon that particular method for determining it. But we can use indirect calorimetry, that is estimating energy expenditure through oxygen consumption and carbon dioxide production, as we talked about before, and I've got some things listed out here. Trust me, about 1 liter of oxygen consumed represents about 5 kcals as we go through this. So what about estimated versus measured resting metabolic rate in persons with spinal cord injury? Gary Farkas, one of our postdocs here in the laboratory, put together a systematic review of persons with spinal cord injury looking at measured resting metabolic rate compared to predicted, and found that of the predictive equations, 7 overestimated the number of calories expended, 2 underestimated, and really, you know, as you read through the paper, what you come to the conclusion is, or what we concluded, is that indirect calorimetry is really essential to determine resting metabolic rate for persons with spinal cord injury. Can you predict energy expenditure? And again, looking back at Collins' work, that is the 3 VA studies where we looked at energy expenditures, developing that compendium, and using 2.7 milliliters of oxygen per kg per minute as one met for spinal cord injury, compared to 3.5 milliliters per kg per minute for able-bodied individuals. You end up with this equation where you take metabolic rate times 1.15 in persons with spinal cord injury, and we can predict their energy expenditure. What about their total daily energy intake? Now, this is going to depend on macronutrients, that is carbohydrates, proteins, and fats. We'll call alcohol, it's not an essential macronutrient, but it is a real macronutrient in our society. And each of those are tied together with certain calories per gram consumed. And I think you all are familiar with that. Dr. Farkas also looked at using a meta-analysis and a systematic review, of over 275 studies. Basically, 12 of them came down to having the information that we really wanted to look at, and demonstrated a resting metabolic rate of about 1,500 kcals per day. Now, when we consider their total daily energy expenditure using our equation, we figured that their total daily energy expenditure was somewhere around 1,700 calories per day. But they reported on average 1,876 calories consumed per day, meaning that they would have gained, these individuals across 12 studies, would have gained approximately 16.5 pounds of adipose tissue per year based on their reported energy intake and energy expenditure. So, you know, the old food pyramid is gone. Well, you can still find it, but basically we're asked to look at some new things. Nonetheless, you can still go to the old pyramid and recognize that, you know, the best foods in order to achieve high nutrient, low caloric density options would be green vegetables, raw vegetables, beans and legumes, fresh fruit, tomatoes, peppers, and mushrooms. That's what we should be eating. However, most people in the United States are up above here in the worst nutrient to calorie ratio, with lots of fat, flour and sugar consumed, oil and alcohol. So maybe a Mediterranean diet would be good. And I would say, yes, that looks good, except if you have a high caloric intake, you're still not going to be able to lose fat. And so recognize that this whole thing to reduce obesity, we need to determine body composition as a starting point, total daily energy expenditure through indirect calorimetry, and then monitor the caloric intake and compare it to the energy expenditure. And make sure, typically we're going to provide multivitamins so that they get the appropriate micronutrients. There's a lot of physical barriers out there for persons with spinal cord injury, or I would say with disabilities, and particularly wheelchair users. There's few exercise specialists to coach them, and there's even fewer fitness facilities available to them. The Lynn Rehab Center obviously being an exception to that rule, and hopefully you all are learning about that. We have an ongoing study we're trying to recruit for. Hopefully we'll open recruitment soon, called Science, where we look at spinal cord injured individuals and try to intervene with exercise and nutrition. This is called SCI, Exercise, Nutrition, Conceptual Engagement, or Science. This is my science project for short, where we are hoping to improve body composition, insulin sensitivity, and lipid profiles by doing home-based exercise and nutrition interventions. So in summary, obesity is a growing problem with our folks with spinal cord injury. It is the central mediator of the metabolic syndrome, and treatment options really need to focus on behavior modification. So I know I've got all of 2 minutes left, but I would appreciate any questions or comments, recognizing that I have thrown an awful lot at you very, very quickly. Nonetheless, I'm open for questions or suggestions.
Quick question.
Dr. Tiozo.
Yes, very interesting. Still a lot can be covered, and but a lot has been done. So thank you for the presentation. My question to you is, I know in obese, able-bodied individuals, we've observed a shift in muscle fiber types from type 1 to type 2B. What's been done and observed in SCI when it comes to obesity, or maybe regardless of the obesity?
Yeah, the paralysis, interestingly, kind of shifts itself so that we end up with more of the glycolytic fibers. But when we exercise, they respond with the muscles that are voluntarily activated, as do able-bodied individuals, although at a reduced rate because of decreased anabolic hormones, et cetera. When we do functional electrical stimulation leg cycloergometry, however, we see there's not a change, unfortunately, to type 1 fibers, but we do see an increase in the fast twitch glycolytic fibers becoming more oxidative glycolytic. And so there is significant potential for that. Nonetheless, electrical stimulation unfortunately stimulates in a reverse order from a physiological recruitment of those muscle fibers that you're talking about. And electricity flows through the path of least resistance, and so activates those fast twitch, the highly myelinated motor units first, and we end up with endurance issues. And that's compensated over time, as we can see. But I think that we've got a limited capacity to increase muscle mass, and fiber type conversion. I don't know that we've been able to demonstrate that. I haven't been able to, and we did look at fiber types in some of the work that I did at the Richmond VA.
Okay, thank you.
Great question. All right, I'm at the top of the hour, and so I wish all of you a great afternoon and a great week. I'll be back next week. Yes, I'll be back next week, but I forget what I'm talking about, so it'll be a surprise. Everybody have a great day.